Lots of you will know Dr. Wile. He's a clinical associate professor with the University of British Columbia Faculty of Medicine. And he's a clinical investigator with the UBC Southern Medical Program Center for Chronic Disease Prevention and Management. He is the lead of the Humphreys Family Movement Disorder Clinic in Kelowna, which is where I met Dr. Wile, alongside inpatient neurology work at Kelowna General Hospital and clinical research in Parkinson's disease with colleagues at UBC Okanagan and others. Dr. Wile trained in medicine and neurology in Calgary, followed by a fellowship in movement disorders at the Pacific Parkinson's Research Centre in Vancouver. He's been practicing in Kelowna for the past 10 years. I have no idea how Dr. Wile has made time to do so much for the society, but we're very fortunate that he has agreed to give a talk for our AGM today. I also just want to add to that really impressive introduction that Dr. Wile is a nice guy who is such a good friend of the society. Thank you so much, Dr. Wile, and I will hand over to you.
Thank you very much. That's a very kind introduction. And yeah, I'm delighted to be here today to see people from so many different places in the province joining us. For my territorial acknowledgement, just please take a moment to think of the place that you live in. So I'm so grateful. I live in the traditional territory of the Okanagan Silks people. This place and its people have been very good to me. They've changed who I am. And so in the presentation, I'll try to highlight the beauty of where we live and the importance of place. It's all very integrated into the presentation. I want to give some disclosures. So it's no secret, first of all, that Parkinson Society BC has been very good to our clinic. So I am in your debt, and I'm always happy to help wherever I can. The images I use in this presentation are either my personal photos. This is from around Golden, BC, unsplash.com, free for use, or otherwise the source is noted on the slide. I have had a speaker honorarium from AbbVie last year, which I offset with a donation to this organization, and a previous consulting fee for Canadian Agency for Drugs and Technologies in Health. So really, I'm grateful as well for the opportunity to speak at my discretion. So I wanted to actually start by zooming out and thinking about purpose. So you all came here today for a reason. Something about this topic, about Parkinson's disease, is meaningful to you. Today, I'm going to ask more questions than I answer, most likely, but I'm hoping it stimulates thought. And I invite you to reflect. I notice that everyone involved in care of Parkinson's has a deep caring inside somewhere, everyone in healthcare in general. And sometimes the intensity of work and pace of work can take us away from that and put distance from that. So it's important to remind yourself of the why you do these things, and why you're working to help others and to work on your own illness symptoms, or help your peers. I'll be talking about some gaps in care today. So I want this talk to not be about those negatives, but about recognizing the gaps that have been filled. It's not possible to move forward and improve care, though, without making honest assessments of where we fall short. I'll talk about where I fall short. And I want to do that without judgment today. So I have gratitude in thinking back about the positive impact actions can have over a very long period of time. I want to start with this classic cartoon. I'm not sure where the original source is from. It's been redrawn many times. This version was from Interaction Institute. The talk is about equity, so I wanted to talk about what this means, really. On the left panel, you see a depiction of what some might say is reality. So some people have a tremendous amount of resources. If you're trying to see a sporting event like a baseball game, you may have a fantastic cushioned seat at the top of a very nice precipice there. Some people may have just enough to be able to view what they want, and others may not be able to because they may be dug deep in a hole. The principle of equality would mean that everyone gets the same kind of support. And for some people who are disadvantaged, the same support as others may not give the same result. The principle then of equity would say that we determine the supports that people need, and everyone gets the tailored support that they need, or the individualized support that's right for them. And then there's a concept of justice, which is, well, why is there a barrier in the first place? And can we look at the causes of inequities and the systemic barriers and try to remove them? So I want you to think about those concepts when we talk about care of Parkinson's disease today. So the game, if we think about that baseball diamond people are trying to see, in this case is access to care, services, and support. So I have 9 innings. This is a scorecard. It's basically 3 things I'll talk about, though. One of them is geography. We'll spend a lot of time looking at maps. And then I'm going to talk about some implementation approaches to some of these challenges. And I'll touch on some topics and some ethical layers to them at the end. This is a photo from where I live in Kelowna, BC. So I'll start by talking about people with Parkinson's disease. This first figure is from a report that's very, very interesting. If you have time to look for it, it's from Parkinson Canada, who conducted an analysis of Parkinson's disease prevalence over a period of time with Public Health Agency of Canada data and Canadian data and a consulting firm. And this is just to show that Parkinson's disease affects Canadians all over the country. The data is not there, but there are people in the territories as well. And although sometimes we look at, there are maybe differences between provinces, it's important to compare figures like this and think about what we're looking at. I wanted to point out in this figure, this is an incidence figure, meaning how many people are diagnosed with new diagnosis in a given population and period of time. That means they're adding to a total number of people burdened by Parkinson's disease in that area over the past year. Prevalence is a different concept, which is how many total number of people are affected within a given population. When we look at the province we live in, we divide this into health authorities. There are administrative boundaries that determine how health services are organized in different parts of the province. And at least for now, there are 5 health authorities and health regions that have different governance. They have different budgeting. They use different software, different data systems. They have different priorities, and they have different service focus in terms of how they organize their care plans. So if we overlay on that some data from the 2021 Canadian Census, you can see in our province, this is a distribution of median age. So if we look at different census areas in the province, we see that there are, on average, older people in darker shades in this census data. And that can sometimes inform the likelihood that people may be living with chronic diseases or illnesses related to aging in those areas with more people of older age. We also can separate the province into segments that are called health service delivery areas. And we have actually a very good data set from BC Centre for Disease Control in a service they call Chronic Disease Dashboard. And this takes data from prescribing, hospital discharge, billing, and they kind of amalgamate that data to come up with estimates as to how many people have an index condition in a different health service delivery area. So those boundaries within the regions here are outlined, and you can see a prevalence rate, which is, again, the total number of people affected in one of these areas. On a color map scale, they're down in the bottom left. So health authorities and hospitals make decisions about their resources and services and what their priorities are based on these kind of more sub-regional data and what's happening on individually in the regional level that a particular hospital might be in. So if we look at this data from BC CDC, I did contact them. They do have newer data. It's just not quite ready yet for the more recent year. This is the most recent available data for prevalence of Parkinsonism. So this may include people with conditions that are not Parkinson's disease, but that may have diagnostic codes and prescribing patterns very similar, like progressive supranuclear palsy, multiple system atrophy, dementia with Lewy bodies, and maybe cortical basal degeneration. People with those diagnoses may also be found by this algorithm they have. But if we look at in the province and where people are living with these conditions, the total number in BC as the most recent estimate from this data is about 16,425. And if you split those up, there's a pie chart there with a color scale for the regions. So the largest number, absolute number, is within Fraser Health region. It's where the largest population is within the province as well. So it sort of stands to reason. So you can think about this when we come back to deciding and discussing, how should services be organized considering where people are living with Parkinson disease. This is a photo from up behind Peachland I took last fall. So talking about specialist practices in BC. If we think again about health regions in our province, you can draw those administrative boundaries and then look at from College of Physicians and Surgeons of BC where there are practices registered for neurologists. So I did this and I extracted that data in September last year, and that's overlaid here on the map with yellow X's. So this highlights where someone who's got a registered practice in neurology is located in BC. So there are, I think, 220 or 230 or so people practicing neurology. And there's obviously large concentrations in areas of focused resource there. So up in the top right, this is reality. This now is a bit more detailed census map about median age within different population areas. And so if we look at a map of age overlaying where neurologists are located, what questions does this raise for you? So just reflect on that. I'll make some further leading questions to consider. So why does this matter? Is a neurologist practice equally effective? Each of these equally effective as a care provider for someone with Parkinson's, for instance? Does every patient, every person with PD or with other neurological illnesses need equal access to a specialist care geographically close to them? Are there also advantages to having focused areas of expertise with clusters of people working in similar aims? So just think about those things while we talk about resource planning, um, because these are people, not yellow X's. They have reasons for making decisions about where they go, and a lot of those have to do with the systems and supports that can contribute to their own career success and allow them to contribute to broader aims. So let's do a thought experiment. So this is now not data, but if we take a number of yellow X's and spread them just evenly across the province, you might say, obviously, this doesn't seem to make sense as a different resource plan. Maybe physician location is actually not the most important resource to consider. So think about this then in terms of any resource that might contribute to care of PD. This is one where I can have geodata to allow this thought experiment. So not all those services, if you think about things like physical therapy, Parkinson's Society BC has demonstrated that it not always needs geographic proximity. There are ways sometimes to deliver elements of care by video conference. Then you'd have to wonder, well, is that the same for a person with PD as a face-to-face assessment? That may differ from person to person or within a person, depending on what the situation is. So does it work as well for speech therapy, for swallowing assessments, or for providing social support? So think about that in terms of different allied providers that we connect with as people with PD and as care providers when we're trying to find a path of care. So some resources may be better suited to serve people remotely, and some may be better suited as a centralized service if it makes it easier for people to connect. So are there advantages then to a different thought experiment where we might collect resources in a different way? So here's an example of where you might try to say, well, why don't we organize a resource by the prevalence density or where we think most people are living with a particular index condition? So if we go back to this figure in the top right, this is our example of equality. We're putting the same resource everywhere and hoping it helps everyone. Here, we may find certain areas of the province have more or less need. And so this is the concept of equity would be providing more in areas of particular need. Can concentrations of expertise like this evenly benefit people throughout the province? Do we still need to have a proportional resource physically located in areas with people living with PD that are geographically remote? Can we support and sustain resources in that way in areas where people need them? Some resources also need infrastructure that's very rare or unique. So a deep brain stimulation surgical program, a gastrointestinal specialist to collaborate to place a PEG tube to deliver a pump therapy and infusion therapy, molecular imaging facilities, scientific resources or technical expertise, allowing advanced research. Uh, you might look at this and say, well, this doesn't fully make sense either for some of those things. So what attracts specialist practice or organized care or multidisciplinary programs to key locations? What allows them to flourish? What allows them to remain in place and grow to meet the need around them? So think about those things while we recognize, of course, people with Parkinson's are not a blue smudge. So everyone's different, and even individuals, if we take one blue smudge and another in different places, the people living there may have different needs based on where they live, the type of population that lives in a certain area. So there are a lot of variables here to consider, and I just wanted to start the talk provoking some of those thoughts. Next, I'll just talk a bit more about clinical services and what we have currently in BC. This is the same kind of map showing you where hospitals are located in the province. This is again from data from IMAP BC. We can take that map and put locations on where there are movement disorder specialists in practice. So among the neurologists in the yellow X figure, we know some are subspecialized in movement disorders. We have a wealth of expert clinicians in BC that are interested in Parkinson's disease. And we're very fortunate that there's foresight in the Parkinson Society BC to help enhance multidisciplinary clinic impact by expanding allied health services in some of these programs, for instance. And we try to create services where they don't exist to bridge the gaps, like I've alluded to, for instance, with teleservices. So if you're here today, you're obviously aware of these services and you're aware of the good work Parkinson BC has done to bridge some of those gaps. And I really can't overstate how impactful that's been, at least where my little teardrop shape is there. So let's talk about implementation and how these factors that we've looked at impact care when we're trying to implement these programs and services. So if we look at our Canadian Parkinson guideline, there are some clear shoulds and should considers in there in terms of services and resources. So one of them is people with Parkinson's disease should have access to clinical monitoring and medication adjustments. That is a physician who's comfortable managing Parkinson's disease. They should have access to physical therapy if they have balanced motor function problems, and speech and language therapy for communication and swallowing problems. And there are some consider recommendations in there, which are slightly softened versions saying those things might be helpful to certain people with Parkinson's disease. So that report I mentioned from Parkinson Canada last fall has, again, a wealth of information. And I wanted to highlight some of the things related to allied health access. This is, again, a sample, and any kind of survey has potential quality and representation bias issues, but it might interest you to see that about half to 2/3 of people with Parkinson's disease see a neurologist specializing in movement disorders. Less than half see a physical therapist. Very few see an occupational therapist, speech pathologist, or mental health professional. So what factors affect access to allied services? Can we help prevent choking or injuries or improve function more effectively if we just fund more staff? Well, this is actually a very hot topic. And when I went to go to BC Health Match, I found the website has changed. We're now calling it bchealthcareers.ca. There's a brand new website. And the reason for this is a massive increase in interest in people in the United States to move to Canada. So there, you can see here, there are some informational sessions very near future for nurses, physicians, nurse practitioners, and allied health professionals about the different requirements they may face if they want to move to Canada. So should we focus on attracting people to British Columbia from elsewhere to sort of get more staff living here who are capable and can help with this access problem? Should we focus on training and supporting people within the province with better educational programs to train people who live here who are likely to stay here? Or should we focus on finding ways to connect people so they feel supported and they feel like they're part of a team or community, then they can grow professionally in? Just some things to think about. I don't have the answer, but I think all of those things are part of the solution. Looking at another barrier to accessing allied health services, there are still significant cost barriers for people with Parkinson's disease. So I've just put in the top right the medical services plan website comments about physiotherapy. So if you look at the data from the Parkinson Canada survey, from those respondents, uh, we've looked at the proportion of people accessing these different allied health professionals. This shows some of the out-of-pocket spending that's typical for people. And it's important to think about that as a potential barrier or reason why people do not actually seek those supports. Further, if you are so fortunate to have an in-home assessment, for instance, with an occupational therapist, to see are there ways that we can make your home safer if you're at risk of falls, if you need help with transfers, if you need equipment in the bathroom, you may find that you have another loan you need to take out because the cost of home modifications for people with Parkinson's disease is also quite significant on average. When we look at insurance coverage for people living with Parkinson's disease, a lot of people really think about medication cost, but these other costs for adaptive equipment, for support, communication aids, monitoring devices, if people need to be living in long-term care, there is a massive gap in what funding and support is available through insurance providers for those quote unquote extras. So I want to tell you a bit about our team in the interior BC in Kelowna General Hospital in what we have renamed now the Humphreys Family Movement Disorder Clinic. I'll start again with just thanking Parkinson BC. It's always bearing or repeating to be so grateful because in 2020, we'd started before that with myself and our clinic nurse and clerical support. And we expanded at that time the clinic program to include allied health services. So we have a point two speech language pathologist. Typically, like last year, about 98 patients benefited from that. A social worker who was involved in 51 patients last year, and a physical therapist who's point 4, 184 patients. Clerical support, I would say the home plate has grown bigger, and we now have a permanent person in that role, Ashley, and we have some new staff members joining us. So our social worker is also new just last month, Erica, and Krista Zeppiger, our speech therapist, has taken over in that role in the last year. So in the dugout, we have managers and directors and allied team leads who are helping us and coming to our team meetings. So I have some flags here as well, just on a little banner to represent the people who've moved on, who've been part of the team in the past. We had a movement disorder practice lead and previous other allied team members and nursing team members. So I can expand more about these. I think maybe we'll spend time on other things and come back to the impacts that those people have had. But I'm sure, as you know, that they're massive. On the basis of when we started, an impression that we had referrals coming from a very vast geographic area, we tried to bridge some of these gaps as well for access by starting a program of telehealth follow-ups. We were doing a randomized trial in 2020 of telehealth versus face-to-face care for Parkinson's disease when COVID-19 kind of changed our plans. I've spoken about that before, so I won't spend much time on it here. I would note that since then, my observation is we have less telehealth appointments over time. I'm not sure I can tell you in full the reasons for that. The vast majority of our appointments have been in person the last several years. Our referral rate, so if you look on the right panel, still exceeds our appointment rate. And I'll touch on some of the reasons and potential solution ideas around that problem. Um, but you can see here just a fraction of our appointments are telehealth appointments, both for new referrals and people I'm seeing in short-term follow-up within the past 6 months since their previous appointment. So we'll get back to sustainability momentarily. This is actually a picture I took outside my house, I think 3 days ago. Beautiful rainbow. So I want to talk about some other services in the province, trying to address some of these gaps in care. Some people might be familiar with this service, but it's really under, I think, advertised, and many people don't know. This is created actually by Providence Healthcare, partnering with Provincial Health Service Authority and BCH. And what this service is really for is for primary care physicians across BC to be able to access specialist advice. So I say across BC, there are sub regions where they have certain services available, for instance, within VCH or other health authorities or health service areas. And there are some provincial services. And one of those is the Parkinson disease and other movement disorder service. So this is a phone line or text request that family physicians can connect to during business hours for advice about people with movement disorders. And I contacted the race team and they gave me some data. So in 2024, there were 121 calls. It's not that much. That's 10 per month, or maybe 3 per week. And the vast majority of them are coming from Vancouver Coastal, and then the island. So it's a resource that is certainly underutilized in other parts of the province. When we see people in the clinic with Parkinson disease, because our capacity is limited within those part-time allied team roles, we of course need to be creative in finding ongoing care options for our people with Parkinson's, and we make a lot of use of community partners, heavily relying on Parkinson BC and a network of people around the province that we know of in speech pathology roles and physio roles and social roles and others that we know have an interest in this area. We have tried to internally maintain a resource map from our region. And like many have before, we find it difficult to maintain because resources are often in flux and shifting with staffing changes. And so we do tend to use some of these services. So Find a Physio BC, Speech and Hearing BC, Pathways BC includes a medical care directory, including where specialists are. For the public, there's also community service directory. And then Parkinson Canada has this Care Finder, which I think is also a new tool. I wasn't aware of it till preparing the talk. But I think what I saw in just searching it, for instance, it doesn't show any allied health providers in Kelowna, which is not true. So like everything, there's just extra layers that are maybe missing. And I think the data sources are really a challenge, maybe something we can invoke the AI wand to wave and fix. So back to this problem where we have more referrals still in our interior health clinic than appointments per year. How do we address these? Well, it's actually a pretty simple equation. So we either have to look at why we're getting excessive referrals, or we have to look at why we're not having sufficient numbers of appointments. So on the top line, we have had to make decisions and set better targets, set clearer boundaries, and focus on what are the core services of the clinic, which is care of people with Parkinson's and related conditions like PSP and MSA and cortical basal degeneration and dementia with Lewy bodies. And we've had to make a decision around boundaries as well. It looks at geography and is it realistic for us to accept referrals from all over the interior or anywhere in the province? Or should we acknowledge that perhaps that isn't the purpose of a single center, or at least it's not at the current capacity? The things that influence appointments are complex and probably beyond the scope of this talk, but I can certainly touch on them. One of them is actually broader support for neurology regional capacity in general. There are competing time pressures for specialists with all kinds of subspecialty interests that have to do with acute care coverage and hospital coverage. Recruitment, going back to those reflective thoughts about what attracts someone to a community, what keeps people there. Those are things I'll touch on shortly. It has to do with, I think, a healthy practice environment. So going back to the wait list, I've mentioned this already. We tried this telehealth approach back in 2020, and at this point, we've decided until we meet a target that we think is acceptable for new Parkinson disease referrals of less than 12 months, which still to me is too long. When I started, I thought I'd like to hit 6 months for a new referral of someone concerned about Parkinson's. We're nowhere near that. So I've decided to set clearer boundaries until we're consistently meeting at least a reasonable target of 12 months. You might ask, well, what is the standard? And there is none. So if you look at the Parkinson clinical guideline, you won't find a wait time target in that guideline. And if you ask neurologists, movement disorder specialists across Canada, I find everyone I'm talking to essentially also is struggling with this capacity issue. Wait times are way too long. None of us find it acceptable. And sometimes that's a difficult thing when you realize that almost every patient you see has been waiting far too long. It's much more difficult for the patient, though, than us as providers. I wanted to tell you about another care gap we tried to approach. We saw frequent in-hospital use of antipsychotics in our patients with Parkinson disease in the interior. And through a really extensive collaboration with a multidisciplinary input within our hospital and other hospitals in the interior health region, and a lot of leadership from Corey Bendall from the Stroke Network from PHSA, and support from Kathleen Scullion, who is our Parkinson's disease practice lead formerly, and Southern Medical Program student. We collected this group of people together to put data around this and cross-reference hospital discharge data with diagnostic coding for Parkinson's with inpatient dispensing information from pharmacies. And we said, let's look at the list of drugs you cannot use in Parkinson's that's in our guideline and look at how often people who have that diagnosis code were given a drug on that list in our hospitals, because that number should be zero. And we now have a way to track and measure that and look at implementation ideas to improve care in hospital, because our people with Parkinson's should not be getting exposed to antipsychotics. I can speak more about that in the question period. Then I want to talk about another solution idea that I think is tremendously important in the long run. If you take a lasso and you look back at these movement disorder specialty practices, I think it would help considerably to have better regional partnerships and provincial partnerships. So I'm aware that on the island, Dr. Kulkarni and Dr. Tuck and their programs in Nanaimo and Victoria do have some synergies there and some partnerships. We're very excited to have a second movement disorder specialist in Kamloops. Dr. Takahashi and I are well acquainted, and she works very hard to care for her patients with Parkinson's. And we'll have another movement disorder specialist there soon. I don't think that's enough for the interior personally, and I can talk more about that at length. But the things that would help create that healthy practice environment to support and sustain an adequate bandwidth for clinic appointments in a region, I think include things like multi-site team care. So in our region, the geography is a challenge. So we want to create systems that work across sites between Kelowna and Kamloops, for instance, and perhaps other sites in the interior, including a shared triage and waitlist system between our sites. We want to support one another. So as a new specialist to practice, Dr. Bessemer joining us in Kamloops, we want to be sure that we have a way to support one another, check in, have conferences and bounce ideas off one another. And also operational links between our hospital administrators will be very important for the overall program success and to support those administrative synergies that we're hoping for. I think we also could do a much better job at provincial partnerships. So that includes patient engagement. So both at the local level and the regional level, we need patient voices in these discussions about what's important for care. I have in the past been really interested to have an advanced Parkinson disease case rounds series across the province. I'll touch on that shortly. I think we're lowish on time. And then there's a lot of opportunity for research collaborations. So what is advanced PD? Well, the definition is in debate, but one definition that's useful and commonly used is the 5-2-1 rule. So if you meet any of these criteria, 5 doses of medication per day are needed to treat symptoms. You have more than 2 hours of off time where symptoms are not adequately controlled despite medication, or more than 1 hour of bothersome dyskinesia with medications optimized, then any one of those things would constitute that moniker of advanced Parkinson disease, according to a Delphi consensus panel, which we can talk about if you like. So in those populations, there are some advanced therapies or device-aided therapies that are commonly recommended or discussed. And so just briefly, you probably are aware of these, but we have 2 infusion therapies that essentially deliver dopamine. And then we have deep brain stimulation, which directly alters brain signaling. So for duodopa, it requires a PEG J tube or a gastroscopy, a jejunal tube to be placed with a procedure by a gastroenterologist in basically a specialized gastroenterology trained procedure. For Vilev, this is a subcutaneous pump. It requires specialized nursing care knowledge and a titration like duodopa does. And we do have with duodopa, need sometimes for wound care around a stoma. For Vilev, sometimes we need to monitor closely for infection or inflammation around the cannula site. Deep brain stimulation requires also a lot of system overhead. So it requires a neurosurgeon, specialized operating room resources, and specialized nursing care and a programming process. So what are the things that determine where those system elements can reside? Well, it's the overhead of creating and sustaining that special resource. In the case of duodopa, having a partner in gastroenterology who's trained in these procedures, knows how to do the procedures, and is willing to be a close contact if there are issues and problems. For Vilev, the overhead is less. We do need specialized nursing care to help start these therapies and to be able to support patients. But it doesn't require a special second specialist and a program that is resourced to start the therapy. Deep brain stimulation is a highly specialized resource that requires a lot of institutional resources and is challenging to distribute. So when we look at how these therapies, these different options are utilized in Canada and in Parkinson disease, again, there are some data from the Parkinson Canada publication from October and from some personal communications that are unpublished. There are estimates of people with Parkinson disease and advanced Parkinson disease and how many people are on these therapies in Canada. So there are a lot of assumptions made in some of these estimates. So I would say that these are good to get an idea of the problem and the scope and scale of the problem, but they're not to be taken as ground truth. We can expect probably around 23,000 people in Canada with what we might consider advanced PD by that 5-2-1 rule. And proportionally in BC, we should have an expectation that there are at least 3,000 people that might meet that criteria. And in Canada, there are estimated to be about 4,000 people on any of those advanced therapies I mentioned, so duodopa, Vilev, or deep brain stimulation. And we might then expect 600 in BC. Uh, Vilev and duodopa. Vilev has been approved for about a year, and there are roughly 300 people in Canada with this therapy. Duodopa has been around a long time, and there are about 300 people in Canada with this therapy. So that should give you an idea of how the changes that are taking place are affecting system planning. We might expect about 45 of each in BC. So if we look back at this map of the health service delivery areas to think about advanced Parkinson disease in BC, those numbers. Um, the number is different here because the number on the prior slide is an estimate that's based on the Canada estimate. Here, instead, if we base the BC data as the starting point for an estimate and use the same crude 20% rate, which has some loose justifications, but I would say again, it's just an idea to get an idea of scale and scope. The numbers are slightly different. We do have some data from Dr. Honey actually on deep brain stimulation throughout Canada from 2018. It would be fantastic to have updated data on this. And it's incredible to me actually that it's so hard to find updated data on where people are living with deep brain stimulation. I was able to collate some more updated information from colleagues at different sites in BC on these advanced therapies. So in Island Health, we have about 6 patients on duodopa and Vilev. You can see the numbers there. But in BC in total, I was telling you, we might expect about 45 of each duodopa and Vilev, and it's about actually, 2/3 of that. And per our DBS nursing team, there are probably somewhere around 600 to 800 people with Parkinson's with deep brain stimulators in the province. And in 2024, Dr. Lang had said they did 75 new insertions. That includes all indications, not just Parkinson's, and 100 battery replacements. So going back to this, one of the things we recognized in the interior is we're probably not going to be able to resource a deep brain stimulation surgical program. We were able to get going do a DOPA program, which has been quite effective, but it certainly is challenging at times to get the tubes exchanged when we need to. Patients who live, for instance, in Oliver or in the South Interior who might have one of these systems and they need support. Well, we need the specific gastroenterologists. We have Dr. Wiesinger in Penticton and Dr. Jahari in Kelowna supporting us. And I'm so grateful for their support. But obviously, it's always hard for them to get an urgent right now problem sorted out as quick as possible. That's where we decided we need to have some way to improve access to deep brain stimulation. And just yesterday and Thursday, we had a delightful time with our DBS nursing team colleagues who came out from Vancouver. We've been doing this for 3 or 4 years, twice a year. And so Minnie and Nancy from the DBS clinic, I'm very, very grateful. This time a surgical fellow came as well. And some of our patients in the interior of BC with deep brain stimulators come to our clinic. I can see them together with the nursing team for adjustments of medications and the stimulator settings. It's a lot of fun and really refreshing change in our approach to care. And the patients are, I think, very grateful for that to be coordinated in one place. I want to touch on one last thing here. I'm almost done. Um, Research. So we're doing research in the interior, and I think of everything in this way. So for our people in the interior, looking at exercise access, one of the main concerns that I have looking at the literature is every single study that you see is at least 30-minute bouts of exercise, and almost always people have to go physically somewhere off-site to a location where they have to have a scheduled appointment for the session. People with Parkinson's often cannot predict when they're going to be able to exercise, and it's often not going to be enough time to drive to a location, conduct the exercise, and return home. So we're doing a clinical trial about what we call exercise snacks. We'll be recruiting this month, and that's going to be 2-minute bouts of exercise twice a day, 5 days a week. And that allows people, I think, more equitable access to an exercise intervention. There's people, not just with early Parkinson's disease, but moderate and advanced Parkinson's also need to exercise. So we need to find ways to make it realistic for them to be able to achieve that. In terms of clinical trials, the other last comment I would make is that I think in clinical trials, the systems for enrolling and following managing patients in clinical trials is very centralized. And that means that mostly people who have Parkinson's, who have a hard time going to a centralized location for a service, like deep brain stimulation or a specialized center where duodopa is available, also may not be able to access clinical trials if they're not physically proximate to them. So that probably means that in most clinical trials about Parkinson's disease, the population that's represented is an urban population that's close to major academic centers that conduct clinical trials. So we need to improve the ways that we consider and distribute clinical trials to allow people in smaller areas and urban areas and rural areas, smaller urban areas that are living with Parkinson's to participate. The concept there is called ecological validity. So if we look at the whole province that we've been looking at map after map, our beautiful province, people live all over. And if our clinical trials are about people who live in the major urban areas, it's a disservice potentially to the science because it's not collecting data from the entire cross section of people living with this illness. So that's what I wanted to share in terms of reflections on equity. This is a big picture talk rather than granular detail about research and studies, and I hope that it's provoked some thought. I'll leave you with a question just to reflect on what matters, what really matters to people with Parkinson's. This is a Little League player. So there are 4,000 children in BC who are in Little League. I found some data. And there are teams in Fort St. John. There are teams in Nelson, Kimberley, Castlegar. So when your family looking to move somewhere to raise kids, what is welcoming and what feels safe for you and your young family? Well, you want a community where you feel there's alignment with your priorities and where your needs can be met. And if a community has the interest in that, they might try and support and create programs like Little League and other programs for kids and families that make them attractive. So we need to think about how we care for people with chronic diseases in the same way. And that's my last comment just to reflect on, apart from the other people and organizations and the gratitude I have. I just wanted to express for all the support that has allowed us to succeed, depending on your definition here in Kelowna. Thank you.